Thank you very much, Professor Osborne, for that kind introduction and also for the kind invitation to join this International Pathology Day. So I'm probably one of the oddities in this audience, being a computer scientist by training. But I hope that I can contribute to this discussion here, understanding that the focus of today's talks has been on digital pathology, and the previous talk has set the scene really perfectly for my talk, where I would like to talk about the role of AI, the potential role of AI in cellular pathology. So beginning with my conflict of interest disclosures, I currently have PhD students funded by GSK, and Philips Healthcare are co-funding the Pathology Center of Excellence on AI in Pathology that I'm co-directing, that I'll talk a little bit about towards the end. And then I've had some previous funding from some of these other entities. But I must say that I'm not beneficiary of any of the commercial activities of any of these companies myself. And all of what I'm going to be talking about is not going to be trying to sell any of the products of any of these companies to you. So I think I don't need to preach to the converted. Everyone knows that pathology is going digital. There's a big push for digital pathology in the UK. I've been involved in this effort for over a decade now, starting off with our digitization of the pathology department in Coventry, Warwickshire, that I'll talk a little bit about. But I'll tell you what I am most excited about with digital pathology. So with the help of these scanners, we can now convert tissue slides into digitized images. And what's most exciting about that digitization is obviously from a lot of what we've heard already from a pathologist point of view, being able to digitize the whole workflow and being able to remote diagnostics, particularly in current circumstances, that's really useful. But from my point of view, what it also means is that lots and lots of pixel data is being generated on a daily basis in every digital pathology lab. And that's where I think a lot of value for future of the pathology is. So in Coventry in Warwickshire, we started off with this trial of validation of digital pathology imaging for primary diagnostics. This is still, I think, the largest of the digital pathology validation trials. It involves 17 pathologists who re-reported more than 3,000 cases, both on digital and on the under the microscope. And it involved 10 different subspecialties with more than 11,000 slides. So quite a substantive trial. I was involved kind of on the fringes right from the beginning of this trial. Lasted for about 3 years and finally culminated in the publication of this paper in Histopathology in 2016. But I think what it also contributed to was a push for digitization and adoption of digital pathology in the UK. And I know that there have been many other really significant efforts in the UK and other places for digitization. I would like to think that this paper actually contributed, this study contributed to the push for digitization in the UK in a big way as well. But again, coming back to the contribution of the digitization towards the future of pathology, just to put things in perspective, each of these tissue slide images, if we think of it as 2.5 centimeter times 7.5 centimeter slide, your regular tissue slide, if we digitize that at times 40 at the resolution of 250 nanometers per pixel, that generates roughly around 100,000 times 300,000 pixels of data. And that raw data is 90 gigabytes in terms of its raw image size. And as compared to your digital radiology images, for example, chest x-rays, each of those tissue slide images is around 85,000 times more pixels than a standard chest x-ray image. And very quickly, we go into the domain of petascale image data, just in terms of sheer size of these images and the number of pixels. And that is actually great news for people like myself, because we thrive on pixel data, being image analysts. We look at developing models that can extract patterns from pixel data. And I think now is an opportune time for AI algorithms to make interventions into early diagnosis and personalized treatment with the help of deep learning algorithms that we already heard about, and the data that is being generated on a daily basis, lots and lots of it, together with the advances in GPU compute, which have actually been quite useful for implementation of these deep learning algorithms in an efficient manner, in order to target some of these kind of low-hanging fruits in early diagnosis and personalized treatment. So going back to the topic of my talk, what is the role of AI, or the potential role of AI in pathology? This is actually one of the most commonly asked questions when I attend a conference or a panel discussion in the domain of digital or computational pathology. Which AI apps are we likely to see soon? And one of those already happened this morning. I was asked exactly this question: what's going to happen in terms of clinical practice? Which of the solutions are going to be seen first up? And my answer to this question is, there is a kind of spectrum of mundanity. On the one end of the spectrum, we have the kind of relatively mundane tasks, which the pathologists, I believe, can do in their sleep. Things like IHC scoring, finding tumor, mitotic counting, albeit they may be a little bit laborious and tedious. And on the other end of the spectrum, they do something really magical. Things like determining or guessing the mutation status of a tissue specimen just by looking at the tissue slide and the morphology and the architecture. And I'll talk a little bit about it. And my feel is that, it's these two ends of the spectrum that are relatively kind of low-hanging fruits. And then it's the stuff in the middle, the outcome-based subtyping and prediction of response to therapy and stratification of patients into various different subgroups according to outcome. I think that's where a lot of further effort is required. Even though there have been few advances in these domains, there's a lot of work that's needed there. So I'm going to talk going forward about some of these applications and work that has been done elsewhere and in our own group, going from left end of the spectrum towards the right end of the spectrum, starting off with this effort that took place in 2016 by the name of Chameleon Challenge Contest. And this was a challenge contest for computer scientists in a conference for biomedical imaging, organized by colleagues in Netherlands. And here the project was, the contest was all about automatically segmenting nodal metastasis in breast cancer lymph nodes. To us, it was quite an interesting challenge because, what this means is that you want to determine exactly where your tumor cells are in the lymph node specimen. And sometimes they can be hiding in plain sight, and other times they may be other mimics that may be getting in the way of finding exactly where those tumor cells are. And they aptly named this contest as the Chameleon Contest because it is sometimes quite difficult to find out exactly where these things are, particularly in the context of algorithms. And this contest actually was quite a successful contest, culminated in the publication of this paper in JAMA. I happened to be the PhD examiner of the first author a day after the paper was published, which was quite a timely publication. But I think it was also a seminal publication in the sense that it led the way in spinning out several companies in this domain, but also led the way in making people believe that this is now time for AI to make intervention in diagnostics. We now have solutions out there that can solve this problem of tumor detection in breast lymph nodes, but also, as the previous speaker has quite nicely elaborated, tumor detection in other applications as well. And one of the major contributions of this paper was this point here, this little green diamond that was a pathologist without a time constraint. And here the orange circles are pathologists with the time constraint. And what it showed was that some of the top algorithms that solved this problem actually performed better than or equivalent to pathologists without time constraint. And albeit this was a very small data set consisting of around 300 whole slide images for breast cancer lymph node biopsies, but I think it demonstrated quite nicely that it is now possible to achieve equivalent performance to human in this particular context, and maybe out to our human counterparts as well for algorithms. And this paper was already mentioned, the tumor detection in prostate biopsies. This was a paper from Memorial Sloan Kettering on clinical grade algorithms for detection of tumor in prostate biopsies, but also in breast, lymph node, and skin as well. And again, it showed that with the help of lots and lots of data, you can generate algorithms that can produce results that are equivalent to human performance, or maybe even outperforming human performance in some cases. Another similar kind of problem, kind of low-hanging fruit on the left end of that spectrum of mundanity, is the problem of detecting mitotic cells. And in this case, recently, just last month, there was a contest that took place in the MICI conference, which is a medical imaging conference, by the name of MIDOG, that stands for Mitotic Cell Detection with Domain Generalization. This is the workflow of our entry to that contest. We take the input image, we do stain normalization, making sure that the stain appears similar in each of these images. As you can see, the stain appearance is quite different. So pathologists are absolutely fantastic being able to use the visual cortex to filter out those variations. But in case of algorithms, all of this is pixel data, numbers that the computer algorithms are crunching. And the numbers can be quite different when you go from one stain appearance to another stain appearance. So we took this approach of stain normalization, followed by mitotic candidate segmentation, and then mitotic candidate refinement, and finally doing the classification with the help of machine learning algorithm to figure out where exactly the mitotic cells are. And we submitted our algorithm to this contest, and we were quite pleased that our algorithm was eventually recognized as one of the 2 winners of this contest. There were several teams that participated in this contest. And I think, again, goes to show that, these algorithms are now able to match human performance or come close to human performance. And I would regard this one, again, as one of those low-hanging fruits towards the left end of the spectrum. I'm sure most pathologists are very good at determining, recognizing exactly where the mitotic cells are and counting them. In case of breast cancer, for example, if you're following the Nottingham grading system, this is one of the key things that you would be doing on a daily basis, and in several other cancers as well. And this is where, again, in a diagnostic setting, these algorithms can hopefully help you in that kind of very boring, laborious, tedious process of figuring out exactly where the mitotic cells are, and sometimes even determining, the right kind of high power fields to identify those mitotic cells in. And the beauty here is that you can run the algorithm on the entire whole slide image, across the entire slide, and can pick out hotspots of mitotic cells. And you can perhaps then go in there and verify the results of the algorithm, and finally put out your own diagnosis using the results of that algorithm. Moving towards the middle of that spectrum of mundanity, I would like to begin with an example of a project that we conducted together with colleagues in Pakistan, looking at oral cancer in particular, which is one of the major cancers in South Asia and Southeast Asia. So here we were working with this hospital in Lahore, Pakistan, on oral squamous cell carcinoma in particular, where in Pakistan, oral cancer is among the highest incident cancers, with the second highest mortality rate and very low 5-year survival, primarily due to the use of smokeless tobacco and betel quid chewing. And there's little known about the key pathology signatures that can help us stratify patients into low risk and high risk groups. And in this case, we started off with quantifying TILs, which are also quite commonly used now in breast cancer. And here we looked at quantifying TILs with a precise score. We call it the TIL abundance or the TIL AB score. And it's a score between 0 and 1 that tells us exactly how abundant the lymphocytes are infiltrating into the midst of tumor. And I'll give you an example here. So this is how it looks like. This is the input image, this one in the middle, the whole slide image, and we recognize the areas of lymphocytes and the areas of tumor. And then we calculate the statistical score that gives us a measure of abundance of lymphocytes in the midst of tumor. And this is how it looks like. We can generate from the original image hotspots of TILs, and we can give single numbers to each of the individual tissue segments. We can also give a single number between 0 and 1 to the entire tissue slide. And using that single number for TIL abundance, we can then stratify patients into low risk and high risk groups with the help of this TIL abundance score. And more recently, we have actually expanded this further into another score that we call the TASIL score, which is also along the similar lines of lymphocytes that have infiltrated into the tumor, but more looking at the boundary of the tumor and stroma. So at the tumor stromal interface, how abundant are lymphocytes. And actually we show that this is a much better indication of patient risk in terms of disease-specific survival for head and neck squamous cell carcinoma. And this is a paper that has just been accepted in the Journal of Pathology, hopefully coming out within the next couple of weeks. Another important thing that we showed here was that this digital TASIL score has a good positive correlation with CD8 positive T cells and strong negative correlation with M0 macrophages. And I think there is some interesting biology in there that we would be interested in exploring further. Here's another example for triple negative breast cancer. Again, a digital signature that we pulled out from tumor-associated stroma, again, using a kind of social network knowledge, and showed that that can help us stratify patients into low risk and high risk groups in terms of overall survival. This is a joint project with Jane Arms and colleagues in Sydney and Queensland. This is another joint work that we've done recently with colleagues at ICR, Dave Cunningham's group, on inoperable esophagogastric adenocarcinoma. And here we've shown that these digital histological markers actually can give us better prediction of response to immuno-oncology as compared to your standard molecular features, which are tumor mutational burden and PD-L1 expression. And I think that's also quite interesting. And as was alluded to earlier, there are kind of wizardry kind of tasks that we're now beginning to see with the help of analysis of H&E slides using AI algorithms. Started off with this article in Nature Medicine, showing that you can predict various different mutation status in non-small cell lung cancers, and recently MSI in GI cancers. And our recent work in this space, we have shown that actually you can increase the performance of prediction of not only MSI, but other colorectal cancer pathways and important mutations in colorectal cancer. This was recently published in Lancet Digital Health. And one of the key contributions here in this paper that we've made is we can not only lay out the prediction heat map of where the hotspots of key signatures, morphological and architectural signatures might be that can contributing to MSI, but we've also shown that relatively high proportions of TILs and necrotic tumor are associated with this MSI status. And in the interest of time, I'm going to skip a couple of other examples that I would have liked to talk about, but I think I would jump to just giving a very brief introduction of PathLake, which is a National Center of Excellence on AI in pathology. And here what we are trying to do is, our vision is to facilitate clinical adoption of AI in pathology with the help of digitization, of course, but putting together well-curated data repositories that can drive AI innovation and do that in a way that can go through regulatory approvals and commercialization and eventually for clinical deployment. And with that, I would like to end by saying that in the end, our objective is to put together algorithms that can be used for clinical practice by putting various kinds of digital features and measures in front of the pathologist so that they can understand better what's happening in this histology landscape that I call, and hopefully that gives them a better handle on the state of the battle, particularly in diseases like cancer, between the immune system and the tumor, and enable predictive analytics for predicting response to therapy, predicting the course of therapy, doing risk scoring for progression, integrated diagnostics, risk scoring for recurrence, and things like that. And I'm often asked, will AI replace pathologists? And my answer to that question, I just point to this quotation that is not the strongest of the species, nor the most intelligent that are likely to survive. It's the one that is most adaptable to change. And I think we've seen from earlier talks as well that AI is here, and it's a disruptive change to the discipline of cellular pathology. And I think we should be willing to adopt ourselves and be willing to accept that change. So with that, I would like to thank the organizers and all the funders and my PhD students and postdocs whose work I have presented. And thank you very much.